2 minutes behind.
Just 12 minutes.
2 minutes behind.
2 minutes behind. Well done. All right. Surgery, set of appliances.
Okay. Now, what's the secret of running a happy practice? Don't run late. Who runs late? Who will admit they run late? I used to run late. It's stressful. You want to live a long life? Don't run late. Honestly, don't run late. Don't run late. Okay. Surgery setup. Are we recording?
Yes, we are. We're recording.
Okay. So must be age appropriate. And of course, that's all. This is all I do, so I can set it up for the kids. Big screen TV. The bigger, the better. This is too small. This TV is too small. The one in my room. All right, this is an old shot. I must take another shot of the current one. My setup is like a pediatric clinic combined with an orthodontic clinic. I don't sit down at all. I do all my dentistry standing up. I used to cut crown and bridge standing up. I do full mouth rehab standing up. I never sat down. Helps your back, and you're always on the move, and you tend not to run late because I had hygiene recalls I had to run out to, and yada yada yada. So anyway, just an ergonomics discussion. So I have 2 rooms, and I just walk in between, so that one room is changed and the other. Usually, I've got a hygienist who helps me out, so they start something and I'll finish it, and then she'll go over and start something and I'll finish it or whatever. You've got to have good photographic records, like not Mickey Mouse photographic records, not dentist quality photographic records. I'm talking about aesthetic, restorative dentist quality, orthodontic quality. All right. The single most important thing you can do for your general dentistry is take good photographs. It literally is a picture is 1,000 words. So you need a digital SLR. You've got to have the right size mirrors. Who noticed the bowl? I put hot water in the bowl, stop the fogging. You can spend like these little gadgets that shoot air, or you can just warm the mirror up. And the kids go, oh, it's warm. All right, so there's certain tools that are part of my practice. This is, those of you who do TMD work know range of motion, opening. So currently, one of our sponsors is Myomate, and they make a really good one. So you should have a sample there, and there's a special. All right. So for the next month or so, 2 months, you can buy with a 50% discount if you quote MU 50%. So they're really important to help you if you do TMD practice, but certainly because I was a restorative dentist, I did TMD work with Steve Olmos, did training with Ortho POS, I don't know who's done that, here at Derek's. So I do everything. And my exam kind of is a combination of everything. So there's certain pliers that I use. They all have different dimensions, and it's just a matter of finding what really suits your needs. Straight hand pieces, a lot of acrylic work, so we have to grind. So I set up a lab grind box in my clinic, and I just grind. I had the infection control people come and check to see if that was fine, and they say, yep. Hot water for the mirrors. When you take ortho records, you need good material. Think of it like, would you just use alginate for your crown and bridge? Now, if you use ortho alginate, then you have something that's stable for 5 days. All right, when you take a bite, don't use a wax thing, use your crown and bridge PVS, right? So the chroma pad impression material that I use is good for up to 100 hours. Right? Don't use the cheap blue stuff. Like, who has problems with their occlusion in their crown and bridge? All right. Who uses alginate as their opposing model? Why? Right? Seriously. It fits nice so long as he doesn't bite. Right? The opposing model is as important. Yes? Don't use alginate for crown and bridge at all. You got to have the right size trays. Because this is how I start, the little itty bitty kids, and I follow them through until they're all grown up. And you can't use adult trays for little kids. We use acrylic repair materials. We have a combination of appliances to rebalance the structure, and of course my exercise program to train the children to use the space wisely. That's the secret. Make the space, learn to use the space. It's not learn to use the little space. It's not make the space and have a good life. It's make the space and teach them how to use it. So we have appliances that I created and modified for the top and the bottom. And I'll talk to you about why I have a lower expander in the coming hours. Because that's the secret. Who can't expand an upper arch? What's the limit of your expansion? It's the lower arch, right? You can't keep going until you're Brody scissors, right? You stop when the teeth no longer meet. You have to stop before then. But if you can expand 8 millimeters in the lower arch, how much more can you expand than that? And the answer is enough to make a difference, like a real difference. So we're actually running a trial in Europe to see if we expand both upper and lower, does that improve sleep disorder breathing? All right, this is being run with the ENTs in Spain and Lithuania and Germany, and using my protocols. So I've modified John Mew's appliance, and I've created my own appliance, which is the lower. So they're both, if you're asking Rico to make it, just say the Wong appliances, and he'll say what? I play around with Bill Hang's appliances. There's no reason why you can't bracket the front teeth. All right, it's not all or nothing. You have a goal. There's lots of ways you can reach that goal. We have appliances that can intrude teeth. Premolars that have super erupted. Molars that have super erupted. It's possible to intrude them. There are appliances that I've created that correct crossbites efficiently and effectively. We can reopen lost space. You lose an ear early, the 6 bite eats up all the space. We can reopen that space. Simple. It's possible to do many, many things with little children because everything is soft. A big part of my practice is they've seen the pediatric dentist and they've pulled out most of the molars. And the serial extraction road is being taken, right? So what do? Well, we reopen the spaces. Because many of them don't have a skeletal malocclusion, they've just lost E-space. But why would you end up pulling out 4 premolars just because you lost E-space if you can reopen that E-space? Crossbites. You know how when you expand, you got a crossbite, you expand, and the good side gets bad and the bad side stays crossed? And that's normal. Well, there are simple ways of forcing the bad side over into a better relationship and maintaining the good side. Right? You just have a little flange that stops the good side from shooting over. That's all it is. Like the body is simple. It just does what it's told. But you've got to tell it the right things. Can you see that? Just a little flange that stops the good side from becoming a scissors bite and forces the crossbite side across. That's all it is. And it turns your 2.5-year nightmare into literally 3 months, we're done. What happens when they have really weird lip mentalis strain and reverse swallows? You can put a wire that hurts them every time they swallow weird. And then they learn to swallow good. And how many times do you have to touch the flame to realize it's not a good idea? Right, we can tell people, oh, don't swallow like that. Or we can put a boundary which has a barbed wire against it and says, touch it and see what happens. All right, the body responds to physical input significantly more so than verbal. Like one of my really bad habits when I was learning to drive, forgetting to use the indicator. I'd turn and Dad said, indicate! And then I'd put the clicker on after I'd done the turn, right? And then I'd be driving along and I would turn, indicate! And then I'd click the flicker. And then one day he stopped. I thought, I must be doing, one, indicate. How wide can you open it? Really, really wide. So long as you can expand the lower arch as well. And then you got to hold it. And then you got to train them to use the space wisely. And when teeth come through, you can guide them. The easiest time on earth to move teeth is when they're moving. So if you are careful and deliberate and smart, you can avoid braces for most of the kids that you treat before 10. We use traction externally if we need to, and we use the big guns if we need a lot of pulling. So this is Dr. Simon Khan. She was the co-author with me in my GoPex book, and she created this external pull headgear. We get them to chew hard. So we cut little bits of medical grade silicone tubing and say, chew them up. All right, so that's surgery setup.
Okay, so we 10 minutes ahead. Do you want to open to questions before we do?
Yeah, let's do some questions regarding surgery setup.
All right, 1 second.